Sorry, just a second. Am I audible? We are going to have two sessions on stents in congenital heart disease. In today's session, we will probably ask some of the basic questions about stents and probably deal with some details about coarctation of aorta stenting, and then we will go on in the next session to other areas. Now it's important to know, like basically as a pediatric cardiologist, we will be in general skeptic about putting in metallic implants into a blood vessel, thereby committing the size of the blood vessel, because the peculiarity of a child is growth, and so the vessel should be allowed to grow. And when we are putting in a stent, we are automatically sort of putting a limit to its growth. So there is always a skepticism about using stents in pediatric cardiology. So we should know why we are doing it. We should know when we are going to do that. Then the question is where. About this where, probably we will be talking about coarctation today, and in the other sites in the next, and then how we do it along with the where. So why stents? Basically, when you do a balloon dilatation, there is going to be an elastic recoil of a vessel. Stents, by its sheer radial force, is going to prevent this elastic recoil. So that you are not going to allow an elastic recoil. The second thing, any blood vessel can be dilated only by creating a intimal and or intimal plus medial tear. If you can't tear a vessel, you cannot dilate a vessel. So the stents immediately tax the intimal dissection so that the dissected intima is opposed back to the adventitium. Now if you extend it, it prevents an acute closure. We know that if you dilate a blood vessel, a collapsible blood vessel can just close again and it can produce an acute closure. So a stent prevents an acute closure. Now you have dilated and you have produced an extensive dissection, you can use a stent to tack the dissection. Now to extend this, if you are having a very long segment stenosis or a hypoplastic blood vessel, if you are going to do a balloon angioplasty, and the mechanism of balloon angioplasty is by producing intimal and medial tear, it's going to produce extensive intimal and medial damage. So automatically whenever there is a long segment stenosis or a hypoplastic blood vessel, you have to stent. And it also produces a long-lasting enlargement to the desired diameter. Like for example, if you do a balloon angioplasty of a fibrotic stricture, there can be a recurrence of the fibrotic stricture, and so you may come out with a good diameter today, but that diameter may fall back after about 2 years or 3 years. This is what is called as the late lumen loss, and this is prevented by a stent. And now, if you have a total occlusion, you can only recanalize by putting in a stent. There is no point in completely occluded vessel. You just balloon dilate and hope that it will remain open. And there are certain structures in pediatric cardiology which can only be stented and they can never be balloon dilated. Imagine the case of ductus arteriosus in the neonate. There is nothing called balloon dilatation of a ductus arteriosus. Imagine the case of right ventricular outflow tract infundibular stenting in a tetralogy of Fallot. There is nothing like balloon dilatation of the infundibular. So certain structures can only be stented. So if you are asked a question about why stenting, you need to summarize the answer as it prevents an elastic recoil, it tacks the intimal dissection. If you have already dissected, it treats the intimal dissection. It prevents an acute closure. It's important in all long segment stenosis and hypoplastic blood vessels. It produces a long-lasting enlargement and prevents a late lumen loss. It recanalizes total occlusions and certain structures that can only be stented and can never be dilated. The history of stents started way long ago by Daughter and Judkins, who used something like a coiled springs to stent the blood vessels. But the formal stent, which is currently what we are using as the slotted tube stents, started to come into clinical practice only in the 1985. The Palmas performed the initial stenting initially in animals, subsequently in coronaries in humans, but at the same time Charles Mullins from Texas started to do it in humans. About the stent choice, how will you choose a stent? It depends on the arterial anatomy. Like Certain vessels with side branches will have some type of stents. Certain vessels which are, I mean, basically a ductus will need a particular type of stent. Yeah, pulmonary artery will need a specific type of stent. Also, a type of the stent is chosen by the personal preference, a person whose experience and familiarity with the stent. And third one will be the dimensions of the stent. Certain, if you want to stent an aorta, you need to have a stent that will go up to 18 to 20 millimeters. If you are doing a ductal stenting in the neonate, you need to have a stent which just goes up to 4 millimeter or 3.5 millimeter. Now the last two things are important: physical properties and lesion characteristics. Let us deal about these a little bit more. What is lesion characteristics? If you are having a calcified lesion, fibrotic lesion, thrombus-filled lesion, extensive plaques with ulceration of the plaques, kings or bends, external pressures. So these are the various lesion characteristics which needs to be taken into account for deciding on the type of the stent. Like if you are having an extensive calcific lesion or a markedly fibrosed lesion, you need to have a stent which is having a sufficient radial force. If you are having a high degree of thrombus-laden lesion, you need to have a stent which has got a PTFE cover which will exclude the stent outside, exclude the thrombus outside the stent. If you are having a significant ulcerated plaque, in your stent design should not be open cell, because a lot of this plaque will be protruding into the stent and cause an intimal ingrowth. So basically the lesion characteristic will decide the type of the stent. There are certain physical characters of a stent that also needs to be taken into consideration. One is the radial force. Radial force is the ability of the stent to resist an external compression. There's also something called as conformability and remodeling. I'll just show a picture to demonstrate what it means. Then there's something called as tapering of the stent. You will have certain areas where the proximal area may have to be wider and the distal area may have to be smaller. So there is something called as tapering of the stent. And of course, if you are having a stent with a very high radial force, this stent is going to be impacted deep into the intima and media, which means there is going to be a plaque prolapse, and so there is a high radial force is going to have high plaque prolapse. So another physical characteristic that is needed to be we need to know is visibility of the stent. Like for example, there are stents which are absorbable stents called magnesium stents, which are not visible at all. You will not be able to see. There are some stents which are strikingly visible. For example, any high molecular weight stents like Cheetham platinum stent, which has platinum in its structure, will have an extremely high visibility. This is what is called remodeling. You are having a vessel which is little bit curved, and now you put a stent. After the stent will sort of straighten out the vessel. So the entire bend is removed. So this is called as the remodeling of the vessel. And what is called conformability? Conformability means when you are having a stent with a little bit of bend in the blood vessel, there are certain areas where the stent is not going to be opposed at all. So these are certain characteristics, like how much the stent is able to conform itself. Obviously, a balloon expandable stent may give some amount of gaps, whereas some of the self-expanding stent, which are like for example called as the smart stents and all, may not give any sort of gaps, and it will completely conform to the walls of the vessel. And if you leave behind some gaps, it is going to end up in some thrombosis, and thrombosis may end up in higher intimal ingrowth. Now comes how will you classify a stent? I'm going to give a lot of classifications here. About the design, it can be what is called as a slotted tube stent or a welded tube stent. I'll come into it in the next slide. Some of these things are very important because people who are practicing in adult cardiology, in coronary medicine, we will know a lot of these sort of nomenclature, whereas people in pediatric cardiology may not be used. So I'm going to make a lot of classifications. Materials, depending on the material, you can have stainless steel stent, cobalt chromium stent, platinum iridium stent, nitinol stent. Stainless steel stent is, for example, the Parma stent, Genesis stent. Cobalt chromium is the MADRAS stent. Platinum iridium is the CP stent. Nitinol stent, most of the self-expanding stents. Then depending on the target lesions, you can have stents in the aorta, pulmonary artery, conduits, veins, intrathecal septum, etc. Configuration, whether it is an open cell or a closed cell or a hybrid cell. I will also come into what is this open, closed cell and all. Then size of the stent, small stent, medium stent, large stent, extra large stent. I'll come into what is the size. Then we have coverage of the stent, whether it is a bare stent or a covered stent. Then the mechanism of expansion, whether it's a balloon expandable or a self-expandable. Then certain special types of stents. special surface treatment like heparin coated stents, drug-eluting stents, biodegradable stents which can either be biodegradable polymer or magnesium ion which just dissolves in the body, or biocorrodable iron. After some time the iron corrodes and goes away from the body. What is slotted tube versus welded tube? Most of the stents that we use are slotted tube stents. That means you take a small cylinder of a metal and then you cut it with laser. So this is what is called as a slotted tube stent. Many of the stents that we use in clinical practice are slotted tube stents. Palmas, Genesis, Intrastent, everything is slotted tube stent. So you can have a tube which is as small as 0.5 millimeter in diameter to have very, very intricate patterns. And that is the reason why some of these coronary stents which are used in clinical practice, a stent that goes to 4 or 4.5 millimeter will hardly be 0.5 millimeter in its initial profile, because the very small tube you can cut it. And this is laser cut in either the crimped fashion or the near crimped condition, so that they have the very low profile. And the older conservative method is the closed cell design, but the newer designs are the open cell designs. I'll come to what is new, closed and open cell later. What is welded tube design? This is basically you bend and you take metallic wires and bend and weld them to form a cylinder. So originally it is not a cylinder, but you take certain metallic wires and make it into a cylinder. One of the classical example of a welded tube design is CT stent, which is made up of 90% platinum and 10% iridium. It is laser welded. So you take wires and weld them, and then you solder them with gold also. 8-6-10 means there is 8 diamond shaped cells in the entire circumference. So if you open out a stent and look at the stent in all the 360 degrees, you will have 8 diamond shaped cells. So there is also a 6-zig, there is also a 10-zig. So a 8-zig can go up to around 22 millimeter in its diameter. A 10-zig can go up to 28 millimeter in diameter. A 6-zig can go up to 12 to 14 millimeter in diameter. So the number of zigs will decide about how much you can dilate it. The minimum length of a CP stent will be 11 millimeter, and it goes by addition. What is commercially available is 16, 22, 29, 34, 39 and 45. It has got an excellent visibility because it is platinum, one of the highest molecular weight substance, but it is a large profile because it has been taken with wires and welded. It has got rounded edges, it's not sharp like Palma stent, it's more malleable and it is MR compatible. It's very important property. What is the difference between open cell and closed cell? If you see this pattern and this pattern, see that there is a cell, it has got an area. You try to put in a balloon into this cell and try to dilate, you will not be able to dilate beyond a particular size. So the cell is actually closed. The cell cannot be made to have a higher area more than what it is shown now. But imagine this cell. This cell can widen out completely. This wire strut can go here, this wire strut can go here. So this whole cell can be widened out. So this is what is called as an open cell stent. This is what is called as a closed cell stent. There are certain advantages of closed cell stent and there are certain advantages of open cell stent. What is closed cell stent? Closed cell stents are one which have got an excellent radial strength. Now the problem about a closed cell design, we will automatically think whenever there is an excellent radial strength, it won't be flexible. It will become like a rigid cylinder. But to ensure that it is flexible, what people have done is they have made certain designs called as flex designs. That means you add a U shape or a V shape or a S shape or N shape in the elements so that it improves the flexibility. It gives a very optimal scaffold for a blood vessel and there is a uniform surface regardless of the bending. And it is less flexible. But in general, even though there is an additional flex designs are possible, in general closed cell design is less flexible. So if, for example, in a transverse arch coarctation which is highly curved, you will not be able to use a closed cell design stent. You have to use an open cell design stent. And a very, very tortuous ductus, you will not be able to use a closed cell design stent. You need to have some amount of flexibility. So open cell design, there is no consistent shape of the cell. You can keep on stretching a cell. So there is obviously some of the advantages are there is less of foreshortening. It is very conformable to the vessel. So a transverse arch you can put it and the stent will take the arch shape itself. And there is less chance of balloon rupture and you can access all the jailed branches and dilate them. You have a If you have a transverse or coarctation with subclavian artery arising from the middle of the stent, you will be able to dilate the ostium of the subclavian artery. But the problem is there is a high plaque protrusion which leads to high intimal ingrowth. When a very, very large balloon is used, sometimes there can be a dumbbell effect and this may lead to foreshortening. Usually, a open cell design stent does not foreshorten. However, if you are using an extremely long balloon, imagine you are taking a 3 centimeter stent and taking a 6 millimeter balloon, the edges will first start to dilate. So as the edges are dilating, the stent will become shorter and shorter and this will result in foreshortening of the stent. Now about the size of the stent, any stent that is between 3 to 6 millimeters is called as the small stent, which is typically used in coronary arteries and PDA. A stent that can go up to 10 to 12 millimeters is called medium size stent, which is used in segmental branch pulmonary arteries, femoral arteries, pulmonary veins and all. And large stents are those that go up to 18 millimeter, which are used in branch PA, vena cava, aorta, homograft conduits. And there are something called extra large stents, which can go into aorta, Fontan conduit, homograft conduit. So based on the size, you can have extra large stent, large stent. Now coming to the mechanism of the stent, balloon expandable versus self-expandable. Balloon expandable stent is the one that has been the most tested, most commonly used. We very, very rarely use the self-expandable stent in a pediatric practice. Charles Mullins takes the credit of starting the balloon expandable stent usage. The prototype of the balloon expandable stent is Palmer's, which is a 316 cell stainless steel stent. So for the students, some of these names, some examiners may come and ask you, what does the 316 mean? 316 means basically these are all coding of metals. 316 means higher molybdenum content, which makes it less corrodable. Iron itself is corrodable substance. No? So when you add a little bit more of molybdenum, then it becomes 316. So there are certain things called 317 steel, there are 304 steel. So basically that is into metallurgy. But what 316 peculiarity is, it contains more molybdenum. And then this L stands for low carbon. Again, it improves it prevents the corrosion of the stainless steel. The merits are, it is very accurate to be placed. You can precisely place where you want. It has got a very high radial force. You can oversize up to 10 millimeters. That means a Palmer's 14 series stent, what is called 4014, 5014 and all, can be dilated up to 24 millimeters. So you have got a lot of room to over dilate. But the demerits are, it significantly foreshortens, it's very rigid, it flares of the sharp edges may be flared and it may injure the vessel. Sorry for the spelling error here. Vessel or balloon may get ruptured and it doesn't bend at all. Self-expanding stents, it has got a very high elasticity. It's also got a super elasticity. So it is either made up of nitinol, which is very commonly used, stainless steel, silver stent, and cobalt alloys, which are the wall stents. The profile is very, very small. It is flexible in all the tortuous lesions. It has got a very low radial stent. So if the lesion is extremely tight, some people will ask, now many stents are not available, so can we use coarctation or self-expanding stent? The radial stent is so low, so sometimes you may end up in coarctation having a significant residual lesion because the stent does not have the radial stent to push the tissues out. And in general, it has got 10 to 20% additional expansion due to nitinol memory. So you deploy a stent at around 8 or 9 millimeter today. After about a month, it may even dilate up to 10 to 12 millimeters. And this continued pressure of the stent on the walls may result in excessive intimal growth. So this is actually like a lot of people who use it on the aorta will say, today we will deploy at around 10 millimeter and come out. It's being a 14 millimeter stent. After some days, it will expand to 14. True, it will expand to 14, but the continued stretch on the aorta will lead to excessive amount of tissue prolapse into the aorta and cause more and more excessive tissue intimal growth, and so ultimately you will lose all the lumen. So it's not an advantage. This additional expansion will actually become a disadvantage. And corrosion from the nitinol also increases the growth. So this is one of the reasons why we don't prefer a self-expanding stent at all. But having said that, there are certain utilities. You have a BT shunt that you have put in, and the BT shunt is acutely closed off. If you want to dilate that particular stent, Let us assume 24 hours ago or 48 hours ago the surgeon has done the shunt, and now you are going in to do a percutaneous intervention. If you try to do a put in a balloon expandable stent, there is a chance of tear of the surgical sutures. But you just put one self-expanding stent, you will be able to completely do. Similarly, there are certain baffles. Yes. Hello. There are certain baffles, like for example, the Sennings baffle, which are having a narrowing. You can put a self-expanding stent. And the third one will be the various conduits. Again, you can put a self-expanding stent. For example, a Fontaine conduit and all. So there are very limited use for self-expanding stents. Now coming to some of these fancier names, biodegradable stent. Basically, yeah, the purpose of a stent is to give a good scaffold. And if you can give a scaffold and produce a vessel remodeling, subsequently if the metal goes off at the end of 6 months to 12 months, that will be very advantageous for the patient because it allows further and further growth in growing children. So the aims of a biodegradable stent will be, it should have a good radial strength, it should have very minimal inflammation, it should avoid an intimal ingrowth, and the stent should completely reabsorb within 6 to 12 months. There should not be any toxic product that should leach out of that stent, and it should be easy to process and easy to sterilize. So these are the characteristics of a biodegradable stent. What are the various stents that are available? Polylactic acid and polylactic acid, 21. These are some of the materials that are tested now in pediatric practice. These stents are being now deployed in porcine and bovine aorta to find out whether they can become prospective aortic coarctation stents in the neonatal future. Magnesium alloy stent has been there in use for the last more than 2 decades, but the problem is it accelerated degeneration and lack of radio opacity. You will not be able to see the stent, so you have to add a gold marker at either end, and there is an accelerated degeneration. You put in the stent and within 3 weeks the whole magnesium will disappear and the lesion may again collapse. Then comes the corrodable iron stent, which is also another biodegradable stent. Growth stents are stents that are 2 halves of the stents connected with PDS sutures. Again, it is experimental, used in coarctation, not much in clinical use. This is one of the questions that is one of the standard thing that you will find in many papers, as well one of the commonly asked questions also. What are the features of an ideal stent? No stent will be ideal, but these are the features of an ideal stent. Ideal stent should have a very low profile so that you can take it through like 6 French, 7 French catheter. It should highly be trackable. That means it is flexible in all the steep curves. You have an aortopulmonary collateral, you should be able to take it deep inside. You have a very tortuous ductus, you should be able to take inside. So highly trackable. Radio opacity and good visibility. Stent should not be something where you are not able to see at all. It should be very clearly visible. It is MRI safe or MRI compatible. There is a difference between what is MRI safe and what is MRI compatible. MRI safe means you put in a stent and then the patient gets exposed to a magnet for some reason. Let us assume you have put in a Palmer's 4014 stent on coarctation of a patient today, and about 3 years later he breaks his aneurysm in the brain and you want to do a brain scan for understanding about his subarachnoid hemorrhage. You put him on a magnet. The coarctation stent that you have implanted will not be thrown out of the body, and so after some time then it becomes like compatible with an MRI. But MRI compatible means you are able to image the stent itself. So you put in a CP stent into a pulmonary artery and you do an MRI on that pulmonary artery and find out what is the lumen of that stented area. So that means MRI compatible will not have any MRI artifacts. But MRI safe means it is just safe to put the patient on the magnet. Predictable expansion and less foreshortening. You should be able to clearly state how much it can expand. Like for example, an Advanta V12 atrium stent doesn't have a predictable expansion at all. You dilate it to 22, say around 12 millimeter, and then you deflate the balloon, the whole stent will collapse again. The reason being, the stent is covered on 2 sides by PTFE, that the PTFE shrinks the stent again. So it's an unpredictable expansion. So we should have a predictable expansion and there should be very less foreshortening. Radial strength should be very good so that it is able to form a good scaffold. It should have low rigidity. Actually, these two are opposite in its characteristics. It should have a good strength, but the stent should not be very rigid because it should not tear into the blood vessel. There should not be any material fatigue. The stent should not fracture. It should be biocompatible. There should not be a thrombus or corrosion. It should prevent the plaque protrusion, and it should avoid intimal proliferation. It should have round and soft edges. For example, CP stent has got round and soft edges, whereas the Pharma stent will have sharp edges. So the sharp edges will poke into the edges of the blood vessels and cause aneurysm at the edges. Redilatation with patient growth. Today you deploy with 14 millimeter, and when the child grows into a big man, you should be able to dilate the same stent to 18 millimeter. Wide struts for blood flow to jailed branches. So there should be, so this is like open cell attribute should be there. It should be retrievable and repositionable in case if the stent is not correctly positioned. So these are all ideal stents, and obviously there cannot be an ideal stent. We need to think about which characteristic is the most important. For example, in a ductal stent, you should only look at what is highly trackable. You need not have a stent with extreme amount of radial strength and all in ductal stent. Whereas in a calcified conduit, the radial strength is far more important. You need not bother about about the profile. You probably can even have a very, very large profile, but the radial strength is more important. So depending on the clinical situation, you have to choose which one is the most important for you. You don't worry about round and soft edges if you are putting in a calcified conduit, but if you are putting it in an aorta, probably you need to be worried about it. So you choose your stent depending on the situation. About the procedure, in general, people would prefer to do it under good anesthesia or under very deep sedation, but this decision is based on how stable the patient is, how much of immobility you want for the procedure, and how much you want to make it simple. For example, avoiding big anesthesia and all will make the procedure very simple. You can complete it in about 20 minutes and come out. Whereas once you involve anesthesia, intubation, extubation, then you make the procedure into a 2-hour procedure. And how much of immobility is needed? For example, you want a complete, precise control over the positioning. Imagine that you are doing a ductal stenting and you are taking a 12 millimeter stent. 1 millimeter pushing it into the pulmonary artery will end up in stent protruding into the pulmonary artery, and 1 millimeter leaving down a little bit of aortic edge will result in ductal tissue still remaining, and so you probably cannot afford to have any sort of mobility while you are positioning the stent in the ductal stent. But the same thing is not the same situation in some other, like for example conduit stent. 1 or 2 millimeter here and there is probably not going to matter. In general, you need to assess the pressure gradient across the lesion and a good angiography to delineate the lesion properly. However, if you have done a previous CT or MR imaging and already you know the anatomy very clearly, these don't become very important. And similarly, about the pressure gradient, in certain areas the pressure gradients are very important, but in certain areas you don't bother about it. When you are doing a ductal stenting in a neonate, you don't bother about what is the proximal pressure, the pressure in the pulmonary arteries before you stent. So you need to be practical in certain areas. For example, in a chronic total occlusion of a pulmonary artery, which you are trying to recanalize and putting in a stent, there is no point in going across and trying to assess what is the distal pulmonary artery pressure. Diameter of the stenosis and the reference vessel. The reference vessel can either be the adjacent vessel. For example, if you are in the coarctation, you can choose the transverse arch diameter or the abdominal aortic diameter at the level of diaphragm. Or in case of pulmonary artery, you can choose the healthier portion of the pulmonary artery or the contralateral pulmonary artery. In a diffusely hypoplastic LPA, the size of the stent will depend on the contralateral pulmonary artery. So the reference vessel may have to be individualized. The length of the lesion, you have to heparinize almost every stenting procedure. You need to have a reasonably stiff guide wire and the sheath should be placed across the lesion. There are certain exceptions. For example, ductal stent and all, you don't bother about it. And the stent should be mounted either with fingers or somebody might use an umbilical tape or a surgical tapes, or there are certain dedicated crimpos that are available also for stents. Now coming to lesion planning. So today we'll see a few things about coarctation, and then like in the next session probably deal with other areas of stenting. Now, the planning of a coarctation stenting will start with the initial echo imaging. So the diagnosis is made on echocardiography. you look at the hemodynamics. So that means blood pressure clinical assessment between upper limb and lower limb, and if the pressure is more than 20 millimeters of mercury, then that becomes an indication for coarctation stenting. You sometimes may do a coarctation stenting even with less than 20 millimeters of mercury in cases where there is an exercise-induced worsening of the blood pressure, or the patient is having significant LV dysfunction, or PDA, or aortic regurgitation, or extensive collaterals that may mask the coarctation gradients. Otherwise, for clinically, for doing a coarctation stenting, you should have a 20 millimeters BP difference between right upper limb and the lower limb that you are you have to document it before the procedure. We have to look at what is all the effects on the left ventricle, like left ventricular hypertrophy, systolic and diastolic function of the heart. The associated comorbidities like bicuspid aortic valve. For example, if you are having a bicuspid aortic valve with a dilated ascending aorta, you should not try to put in the guide wire into the ascending aorta, because you may tear the ascending aorta, create a dissection on the ascending aorta, and the patient may present with an ascending aortic dissection a few days later after you complete the procedure. So in such patients, identifying that there is a bicuspid aortic valve with a dilated ascending aorta, you may have to park the guide wire deep into one of the subclavian arteries rather than into the ascending aorta. And you need to look at how much is the aortic root enlarged, how much is the ascending aorta enlarged. There are certain, in echocardiography, you need to carefully look at all the segments of the aorta. So this is the ascending aorta, this is the transverse arch. The transverse arch has got two parts, the proximal arch, which is between the innominate artery and the carotid artery, and the distal arch, which is between the carotid artery and the subclavian artery. So we need to measure the proximal arch and the distal arch diameter. The coarctation balloon should not be chosen more than the distal arch diameter. And this is the isthmus, the portion beyond the subclavian artery is the isthmus. And this is an example of a discrete membranous coarctation. So in such cases, this may be an exception to the rule that stenting is always a better strategy. In general, stenting has got certain advantages I mentioned in the beginning itself. But in patients who are having a very, very discrete membranous lesions like this, there may be a role only for balloon dilatation. Let us see this particular patient. So this is a discrete membranous coarctation, and so the plan will be to put in a balloon which will be equal to the size of the distal transverse arch or the isthmus, because none of those areas are hypoplastic, and keep it inflated for about 20 seconds. While in valvuloplasty, you inflate and immediately deflate, because the cardiac output will be stopped if you keep a balloon inflated in aortic valve or mitral valve or pulmonary valve for 10 seconds, 15 seconds. In coarctation, you need to keep the balloon inflated for at least around 20 seconds. Why? Because the mechanism of balloon dilatation is intimal tear. You have to tear the intima and media. But if you keep the balloon inflated for about 20 minutes consistently, you are tacking that intimal flap back into the media, so that the torn segment is not loosely hanging into the aortic lumen. So successful result of a balloon angioplasty means there should be a tear. So the tear will look like this. So this is a tear of the intimal tear. This is what is called a therapeutic tear. If you don't tear it at all and the vessel looks like without any torn segment, in fact, there is a bright possibility of a recoil of that vessel. Now, whenever there is a tear, you need to carefully keep looking at the edges here, whether there is any extravasation out of the lumen. And here what you are seeing is all the branches only. So if there is no extravasation, that means the tear is confined to the intima and media. But having shown the mechanism of a balloon dilatation, this is the major concern of this procedure. So now let us look at the same patient's echocardiography. You can see that intimal tear here. So this is what is the basic mechanism of balloon dilatation, and this is precisely, since there is an intimal tear, many people will consider stenting is a better option, because you are immediately tacking this intimal tear. So what is the role of stenting in coarctation? It does not allow any recoil. It gives a sustained hemodynamic result. Not like you have a good gradient reduction today, and about 6 months later again the patient gets back all the gradients again. So there is a sustained hemodynamic result. It tacks the dissection. It avoids an uncontrollable tear. You cannot have a tear that starts from the descending coarctation and going down up to the abdominal aorta. Because your stent is going to tack the dissection right at the place where the intima is torn, and so you are not allowing the dissection to progress. And it also gives a room for graded dilatation. Let us assume that you have started a balloon dilatation, you have gone up to 10 millimeter, there is an intimal tear, and now you have a residual gradient of 20 millimeters of mercury. Now what will you do next? You cannot go for a further dilatation. But if you have put in a stent, you can keep on dilating it further. This 10 millimeter can be dilated to 12, then to 14. You can keep on increasing the dilatation. Graded dilatation is possible. What are the specific anatomical indications for a coarctation stenting? If you are having a coarctation that is having either a transverse arch hypoplasia or an ischemic hypoplasia, you cannot have balloon dilatation alone, because balloon dilatation will work on the coarctation segment but not on the ischemic and transverse arch hypoplasia. So you have to go for stenting. So ischemic hypoplasia or a transverse arch hypoplasia is a definite indication for stenting. If you are having a coarctation which is having an associated PDA, you have to go for a covered stent, because otherwise you will not be able to address both the lesions together. So when do we decide for an elective stenting? If there is an ischemic hypoplasia or a transverse arch hypoplasia, you have to do a stent. If there is an associated PDA, you have to go for a stent. In general, in all the adolescents and adults, you have to go for a stent, because you cannot afford to have an intimal dissection and the dissection progressing on to a frank aortic dissection. In extremely tight coarctation where the balloon to waist ratio is more than 3 times, you cannot afford to have just a balloon dilatation. You will tear the vessel. So you have to go for a stenting. And in all near interruptions, you have to go for a covered stenting. So there is an option for coarctation with PDA where you sometimes, if you don't want to put in a covered stent, you can put in a device, close the PDA, and then stent the coarctation, so that the stent now creates a lumen of the aorta and the device completely closes the PDA. So this is one of the alternative options, but in general, covered stent will be a preferred strategy. How will you plan a stenting? It's based on some form of three-dimensional imaging. You should have some method of three-dimensional imaging, and that will be useful for planning the stenting far better. Either a multi-slice CT, which is the most commonly used, MRI, which is rarely used, or rotational angiography. So multi-slice CT is the most robust method of imaging. Extremely tight coarctation may be sometimes interpreted as interruptions in a CT scan, because blood may not reach the lumen, and you may find that this is like an interruption. However, when you take a guide wire, the guide wire will easily walk through. But there is a problem. It involves additional radiation. This is an example of a very tight transverse arch coarctation in an extremely tortuous aortic segment. You are able to see the 3 branches, and between these 2 branches is a tight coarctation, which is completely hidden because all the branches are dilated, and you have huge collaterals. And in such a tortuous arch, see, this is the stent across that same vessel. This sort of management can only be planned based on an extremely good 3-dimensional imaging that we have done previously. So this is a transverse arch coarctation that was based on that CT imaging. MRI, it always people say that it has got a lot of advantage, like no radiation. However, we need to understand that it needs a very long imaging time. It may take about 1 hour to acquire a good MRI. Resolution is far less than a CT, and it is an evolving technology. So all the technicians may not give the same good pictures, and so we may expect MRI to give the results similar to CT only another 10 to 20 years later. Rotational angiography is within our own area, which we ourselves can do a 3-dimensional study. So it can be planned at the same time of the stenting. The dose of additional contrast is not very much because we dilute the contrast, and the 3D overlay may help in guiding the procedure. So this is a patient with a PDA with the coarctation, a tight coarctation, where a rotational angiography is being done. The advantage of this rotational angiography is you can freeze the rotation at a stage where you want, and in that particular stage, if you are able to get the maximum best delineation, then you can, for example, I want to have, this is the distal ischemic portion, the coarctation is seen here, and this is the PDA. And we can obviously go and look at what is the angle here. So this is 37 degree. So I can plan the entire procedure at this 37 degree and start putting in the stent from here to here at 37 degree view. So rotational angiography gives a quick view about what is the angle that is going to be helpful for us. So rotational angiography is also extremely useful if there are the side branches are extremely close to the region of the coarctation. The technique of rotational angiography, you have to use a 2:1 contrast dilution. That means, say for example, 60 ml of contrast with 30 ml of saline, dilute them. You have to go for a 180-degree spin. There are certain new machines which are even coming up to 210-degree spins. The speed will be 40 degrees per second or 45 degrees per second. It's a 4.5 to 5 second rotation. Injection will be done at 15 to 18 ml per second. Since you have diluted the contrast, the viscosity of the contrast comes down. So the catheters will even be able to inject up to 18 ml per second. And usually you try to do a rapid pacing to reduce the cardiac output, because you will be able to retain the contrast in the aorta for a longer period of time, and apnea also is desirable. And how do you do a standard coarctation? The angiography is done with preferably a measuring pigtail. The measuring pigtail, using this, you identify what is the ischemic diameter, the transverse arch diameter, and the descending thoracic aortic diameter. The stent is chosen according to the transverse arch diameter or the diameter of the abdominal aorta. And if there is a previous CT image, then choose the appropriate view based on the CT image. But if you have not done any imaging at all, either a lateral or an LAO view with 20-degree caudal will most of the time open up many of these coarctations. You can see that the discrete coarctation is nicely seen, and this is LAO 40 with a caudal of 30. So LAO with caudal of 20 or 30 or lateral with a caudal of 20 or 30 is going to open up the coarctations far better. The techniques to stent safely: choose a balloon diameter roughly equal to the proximal isthmus or the distal transverse arch. Park the guide wire tip if possible in either subclavian artery to avoid an ascending aortic injury, especially in patients with bicuspid aortic valve and dilated ascending aorta. Take the balloon stent assembly always within a long sheath. It's better to avoid taking the balloon stent assembly bare over the coarctation area. Avoid stent slippage by very minimal inflation of the balloon, so that the proximal and the distal ends of the balloons are slightly inflated, then the stent doesn't move. You should not give a negative pressure on the balloon and then load the stent, because the balloon will be highly collapsed and the stent will slip. Use a sheath that is 3 French larger for all the covered stents. Use indeflator to slowly deploy the stent. Rapid pace to reduce the cardiac output during stent expansion. And keep sheath tip immediately distal to the balloon to prevent a downward drift of the balloon. Otherwise, the balloon may get melon-seeded. I'll show some examples. So there are certain special situations. I'll go into each one of them. What is a near interruption? This is a patient with something called as near interruption, where you inject into the proximal area. You are not even able to see the contrast spilling down into the distal segment. So this is the distal injection. So this is a complete interruption. And in such cases, it will be difficult to cross from below, because the distal portion will be very aneurysmal. So in such cases, you actually cross from the proximal area, which is a tapered segment, and snare out the wire. And after you snare it out, then with the guide wire, then advance the pigtail and make an angiography. Here you have found that the coarctation, I'll again run the picture. The coarctation is actually hugging this 5 French catheter, which means that the lumen is less than 1.7. It is just hugging. So in such a case, the balloon diameter to coarctation ratio is only around, we should not go more than 3 to 3.5. If you are going more than 3, then you are going to have a rupture of this. So let us assume that you are going to put in a stent. You have bare stent on this area. What the maximum size that you can dilate, this is 1.7. So 1.7 into 3 will be only 5 millimeter. So in an adult patient, to put in a stent which is only 5 millimeter is not going to give any sort of hemodynamic result. So in these sort of situations, you can choose what is called as compliance testing by putting in a small balloon and try to dilate it slowly. So this is a very low pressure balloon, which is just dilated at 1 to 2 atmospheres and create a waste. The advantage is now we have created a lumen, and so there is a lumen that is created. Now what was originally a less than 1.7 millimeter lumen that allowed a pigtail catheter now has become close to 4 to 5 millimeter. Then with that diameter, then cross again with the pigtail, measure it, and now we have a vessel that has grown up to around 4.5 to 5 millimeter. Then use now a covered stent and go 3 times more. So that means 15 millimeter stent. You can go, this is a 16 millimeter big balloon. and the covered CP stent is being deployed. So now what we have shown here, in patients who are having an extremely narrow coarctation, there may be a role for a gentle compliance testing by using a very low profile balloon. This is what was followed in the COAST trial that was conducted recently. As a mandatory requisite, the compliance testing was done with a low pressure balloon. We'll come to it later. So this is the final angiogram of the same patient. So in order to cross the lesion was initially crossed from top and it was snapped out through the bottom. Now some of the other problems are stent malposition, migration, and balloon melancholy. This is a patient with a post-surgical recoarctation. You can appreciate that actually this coarctation, the surgeon has done what is called as a left subclavian flap aortoplasty. So that means the subclavian artery has been cut off. So this is a subclavian that is filling from the vertebral stele. This is the carotid artery with external and internal carotid, and this is the subclavian artery. So this patient gets a severe recoarctation, and so this is a CP stent that has been mounted, and the guide wire is parked in the coarctation. The stent is well placed on this coarctation, but when you are deploying the balloon, what happens is the balloon sorts of melon feeds the stent into the carotid, and the balloon slowly comes out. One of the reasons why this happens is because the stenting is on a very rigid vessel, which is a post-surgical coarctation, and the melon seeding is also due to very long balloon in a curved arch segment, so that longer balloon actually is being pushed out by the smaller carotid artery, and so the balloon tends to migrate down. This could be prevented by keeping the sheath tip very, very close to the stented area, so that passively you resist the balloon from getting distally melon seeded. So in this patient, a subsequent low pressure balloon, low profile balloon is taken into the stent and deployed and pulled back, so that you get the stent back into its desired location, and then subsequently you dilate it, and this is the final position. You can see that these are the two blood vessels. The subclavian was already spared. It was a post-subclavian flap aortoplasty, and so this is the final stent position. So what we saw in this example, you can see what is called as the stent migration, the balloon melon seeding. So these are some of the problems associated with coarctation. Another technique that is often used in coarctations is what is called rapid pacing. So after you position the stent across the coarctation, you employ rapid pacing, which will reduce the cardiac output and which will prevent the stent from migrating distally. So this is how a rapid pacing is being utilized. And this is a Palmas 4014 stent using a 16 mm Z-med balloon. So a rapid pacing is a method of stabilizing the stent. So the methods of avoiding a stent malposition is rapid RV pacing, avoiding long taper balloons, like for example Max LD, Atlas, these are all long taper balloons, avoiding balloons that are too longer than the stent, and using bib balloons. These are all methods to avoid a stent malposition. Mounted stents in general do not go for malposition, because for example the only mounted stent that is available now is Atrium V12, Advanta Atrium V12 stent, which currently is not available. Balloon rupture is another problem. So this is a patient who had a transposition of great arteries. The ductus which was divided has been clipped here, and this is a severe coarctation that has developed at the ductal site. So a stent is being mounted, a 29 mm CP stent on a 12 mm Z-med balloon, and as the stent is being deployed, the balloon ruptures. You can see the balloon, the contrast leaking out here. Basically, why did this happen? The compliance of this vessel is very, very low because there is a metallic clip on the anterior wall of the aorta. So now that balloon has ruptured. So you take another smaller profile balloon through that partially deployed stent, and then you expand it so that you get the stent fully opened out. What altered the compliance of this aorta was this metallic stent, and this is another reason why pre-dilatation is sometimes performed. So the indications for a pre-dilatation will be to check the compliance of the blood vessel, to create a lumen in almost interrupted aortic segment so that you can pass a stent. So this is the final stent position of that same patient. Now about transverse arch stent. This is a 15-year-old girl with a pre-subclavian tight coarctation with a small ductal aneurysm here. So we are using a 29 millimeter covered non-covered bare CP stent because we have to allow side flows through the subclavian artery. So we can now see that the stent is being positioned, and as we are deploying the stent, the problems about this transverse arch stenting is that because they are in a curved segment, there is a melon seeding. You see now the same phenomenon is happening. There is a melon seeding, and the whole stent the balloon is being ejected proximally. In fact, you see here also the sheath is being pushed down, in spite of the sheath being kept at an appropriate position. The same principle is followed. You pass a low pressure, low profile balloon to the proximal area and first get it deployed. And once it is getting deployed, then subsequently things become stable. So basically in these 4 or 5 examples, I had shown certain common problems that happens like balloon rupture, balloon melon seeding. So these are some of the complications of the coarctation procedure. Now comes to what is the international data. There is a congenital consortium of interventions in structural diseases of the heart which was formed, and they analyzed in 2010 close to about 300 patients in around 34 centers. Majority of the centers were in US. Just a couple of centers in Europe, one in Guy's Hospital London and one in Frankfurt and one in Brazil. All the other centers were in US. They deployed a total of 351 stents. That means 16% of the patients had more than one stent due to stent migration. And 82% of the patients were done on general anesthesia. I had talked about to keep the procedure simple, sometimes we might do it entirely on just local anesthesia. However, in this registry data, it was 82% of them on general anesthesia. And about 17% of them were intentionally staged into 2 procedures. That means in a small child, you just deploy with a smaller diameter and then intentionally go and post-dilate after about 1 year or 2 years. 14% of the patients only had a pre-dilatation, which means for checking the compliance, they had checked only in 14%. In about 1/5 of the patients, they went in for a rapid pacing to allow some stability of the stent. 45% of the times they kept the wire in the ascending aorta, but in the remaining patients they kept it in the arch. I discussed about what is the advantage of keeping it in the arch branches. Balloon to waist ratio on an average was around 2, but it varied between 1 to 9.2. 57% of the patients, the balloon to waist ratio was more than 3. And in 13% of the patients, it was even less than 1.5. That means even very, very mild coarctations were sometimes stented. Flaring of the edges was done in about 20% of the patients. 13% of the patients had an arch vessel overlap. 96% was the acute result. The success was unrelated to weight of the patient. So even in a smaller patient, they had a good result. So these are some of the facts that we need to understand. Yeah, coarctation can be considered as a primary therapy for even a small child of around 5 years or 6 years, because weight does not lead to poor success. And the stent type, balloon type did not matter. Compliance testing was, whether it was done or not, it doesn't matter. Transfers of hypoplasia were also equally successful. Stent migration happens in about 3% of the patients. Aortic wall injury and aneurysms happen in about 1% of the patients. Balloon rupture happens in about 0.3. Femoral pulse loss happens in about 1%. I just showed some examples of all these things in the previous. All throughout these years, FDA never approved a vascular stent. So if you look at all these stents, they'll be called as biliary stents. They'll be called as iliac stents. And a major intravascular purpose, FDA never approved a stenting because there was no data. So for the first time, FDA controlled US trial was started called the Coast trial for testing the role of a stent in a blood vessel, and about 105 patients were enrolled. With the outcome, what was looked at was reduction of the gradient and duration of hospital stay. They also looked at how many of them had adverse events and how many of them had paradoxical hypertension, because these were the problems of surgery. So they wanted to see, in comparison to surgery, how many of them had adverse events like aortic rupture and how many of them had paradoxical hypertension. The inclusion was, while in the previous CCISC data, even very young children were taken in the inclusion criteria in Coast trial was patients should be more than 35 kilograms and it can involve both the native and recurrent coarctation. The VPA difference should be definitely be more than 20 millimeters of mercury. Compliance testing was always part of the study, and whenever a compliance testing was done and there was a waste on the balloon for the stent was taken less than 1.4% of the waste of the balloon. It was only a bare CP stent that was used. 104 patients had successful result, almost all of them except one. Aortic aneurysm was found in about 6% of the patients, or in other words 5% of the patients. 14 patients had stent fractures subsequently on follow. It was mostly seen in large stents, but there were no clinical problems associated with stent fractures. In general, this is a welded tube stent. I told that the CP stent is a welded tube stent, so it is more prone for stent fractures. Whereas the slotted tube stents like Palma stent, intrastent and all are less prone for stent fractures. 19% of them had re-interventions and most of them were elective. Now there is a continued study called the Coarctation study, which is a covered stent trial, a US FDA sponsored trial which is going on. So in short, in the messages about coarctation, in cases with very, very tight coarctation, snare the guide wire from the top, cross from the top and snare it from below. Pre-stent balloon dilatation is sometimes used to create lumen and check the compliance if you feel that the vessel is not going to be compliant at all. Avoid a long taper balloon in the aortic arch. The stent length should be equal to balloon length. You should not choose a balloon which is longer than the stent. High pressure balloons sometimes may be needed in postoperative non-compliant aorta. Rapid RV pacing will prevent migration in patients with mild coarctations. Keep a covered stent and keep low profile high pressure balloons always ready in the cath lab for any of the stent migrations. Radial access arm catheter will be useful to guide the position of the arch stents. So in the next session, we will continue with pulmonary artery stent, RVOT conduit stent, native RVOT stent, intra-atrial septal stent, Fontan conduit stent, venous stents, and ductal stents, both in drug-dependent systemic circulation and pulmonary circulation. If there are any questions for today, we'll take it now.